This video is going to talk about making medication cards or medication information sheets to use for help in clinical and in pharmacology and lab. People have been making medication cards since well before I was in school. I remember having a recipe card box full of 3x5 med cards that I started when I was I guess a sophomore, and went on until I was a senior in college. I know that when we first started this program, students complained vociferously about having to do med cards, and so we decided, well, maybe they didn't have to do handwritten med cards. But then, you know what? The thing is, if you take the time to write it down, you will be more likely to remember it. I know carrying around a bunch of cards is not very useful, but there are other ways to do this, and you can use a file, say in the cloud, that you can access on your phone or whatever, and that will be more useful for you. So if you start this file now and then add to it, you will have a lot of work done when you get to Med-Surg in the fall, so you won't have to keep looking up the drugs that you give over and over again, because you'll have them right there in your file. This will also give you good practice at separating out all the noise versus the important information. If you look in those drug books, there are pages and pages full of details, and most of those details really aren't that pertinent to you. And so if you can write these down, take a look at it, and think about it, then it will give you some practice sorting out the important things. Finally, this will help you see the information in a clinical context, because if you use nursing care and assessments on your med cards or your med information sheets, that will help you think about the medications clinically. Do you need to use a template? No, you don't. But I think it makes it easier to find what you're looking for if you have the information in the same place for each medication. ATI has a really good active learning template for medications in their resources section. It's a fillable PDF, and so you just open it and type in what you need, and the font magically gets smaller the more you type. It's a pretty cool thing. It's in Canvas, and then of course it's also in ATI. The problem with this is some students have told me they had trouble writing on it, or if they did and wanted to print it out, then what they wrote didn't quite print out right. It was a little wonky. So, take a look at it. If you like it and it's useful to you, I encourage you to use it. The website Nursing is something that you can purchase subscription to, and you can, I guess they have books now and all kinds of stuff, but they have a medication template that is in your Canvas class as an example, and it's a pretty good one too. It's a PDF. I don't think it's fillable, so you would have to print it out and write on it, I think. I've also made a template in a Google Doc. I've put this in Canvas. You can download it to your Google Drive and then edit the format so that it works for you. You don't have to necessarily use the format that works for me. Then you can create your own drug library. So if I were going to do this, I would have on my Google Drive a big old file that said med cards, medication info, medication information sheets, something like that. Then in that big file, I would have subfiles that said cardiovascular drugs, GI drugs, neuro drugs, whatever. Then you could just go crazy in those subfiles and just continue to categorize the drugs. Say you could do cardiovascular, then you could do antihypertensives, and then in that you could have ACE inhibitors and ARBs and beta blockers and all that kind of stuff. But eventually you'll get to a place where you want to put the individual files, and then you'll name those the name of the drug. So in that case, this particular one, I chose cardiovascular drugs, and I put down propranolol, which is a beta blocker. Doesn't matter how you organize this. The point is, you'll have a lot of work done for yourself already for the fall in 142 if you start now. So when you're making your medication card or medication information sheet, the first thing you're going to want to do is start with the name. As you learn in pharmacology, medications have two names, generic name and a trade name. The generic name is the only name you will see on the NCLEX. So if you're going to memorize a name, memorize that one. The other good thing about generic drugs is that their suffixes will give you a clue about what drug class they belong to. So if you have a beta blocker like atenolol or propranolol, you'll notice that LOL is on the end. If you have a proton pump inhibitor, a PPI for instance, like omeprazole, lansoprazole, AZOLE is on the end. Pril, PRIL, is for ACE inhibitors, so lisinopril is an example of that. So there are many different drugs that fall into this category, and if you know the suffix, you can pretty much reason out what the drug class is. The trade names vary with the manufacturer, and what happens is they create a drug, they get a patent, and then after the patent runs out, it becomes generic, and then other manufacturers can manufacture that drug too. So that's why there's just a ton of trade names for one generic drug, and it's the same drug. I've said before that you'll never be able to know all the names of all the drugs, but it's good to know the drug classes, especially the big ones that you give all the time. There are two types of drug classes. There is a pharmacologic or a chemical drug class, which tells us how the drug works in the body at a cellular level. For instance, a beta blocker blocks beta-adrenergic receptors in smooth muscle and in your AV node. ACE inhibitors have to do with blocking angiotensin receptors. Proton pump inhibitors have to do with blocking the proton pump that makes the acid in the stomach, and on and on and on. So those are the things that happen in your body at a cellular level. But they don't necessarily tell you why you're taking this drug. So that's where the therapeutic class comes in, and this is the one I think is useful because it tells you what does it do in the body as a result of that action. So if I have a beta blocker and it's blocking the beta-adrenergic receptors in my smooth muscle, what does that do? It dilates my smooth muscle in my vessels and lowers my blood pressure, so it's an antihypertensive. Same thing with the proton pump inhibitors. I would have no idea what that meant, but what that does is that decreases the amount of acid that my stomach produces, and therefore it's an acid reducing drug, and that makes perfect sense because then you know that has to do with gastric reflux or ulcers or whatever. So the therapeutic class tells you what the drug is for. Lowers your blood pressure, decreases your pain, whatever. The therapeutic use for a drug sort of follows the therapeutic class, so it might be similar to the drug class. So if you have an antihypertensive, you're probably going to have it prescribed for somebody who has hypertension, right? But it may be different for different patients because not everybody who gets a beta blocker is hypertensive. Sometimes they give them post-MI because it decreases the workload of the heart. Sometimes they give it to people who have migraines because it decreases, prevents people from having migraines. So there are lots of different reasons why people take the same medication, and it's important for you to understand which reason your patient is taking it for. There's also something called an off-label use, and that refers to what the medication is approved for by the FDA. So the FDA approves things for very specific purposes, and then after we use a medication for that purpose, after a while, we collect data and we realize, it does this other thing too. You know, the beta blocker, we gave it for hypertension or to protect the cardiac muscle, and we realized in people who had migraines, took their migraines away. People who took ACE inhibitors for blood pressure, as it turns out, those protect the kidney, and so sometimes they will give those for people who have renal failure. So it starts out as what we call an off-label use, and then eventually the FDA will probably approve it, but you'll see that quite a little bit. Another one of those drugs is gabapentin. It's an anti-seizure medication, but it also works for pain, particularly pain associated with diabetic neuropathy. So the therapeutic use is why is it given, and it may be different for different patients. So the action of the drug is sort of similar to that chemical or pharmacologic drug class. It basically talks about what does this do in the body at the cellular level to achieve the desired outcome. So for instance, if we have a beta blocker, we know that it blocks beta adrenergic receptors, and so it decreases the beta stimulation of smooth muscle, relaxes it, and it vasodilates. And so quite often the action then will be what happens at the end. It's vasodilatation. Sometimes we don't know exactly how drugs work. There's a whole lot of drugs like that. We just know they work. And so sometimes you'll see, we really don't know exactly how this works, but we think it might do this. So sometimes you don't know the specific action, but sometimes you do, and it's quite often related to that chemical or pharmacologic drug class. So we've talked about a whole bunch of different things that sound alike here. We've talked about the generic name, and the generic name has a suffix which sounds a whole lot like the drug class. That would be the therapeutic drug class. Excuse me, that would not be the therapeutic drug class. That would be the pharmacologic drug class. So like a beta blocker, an ACE inhibitor, or something like that. We have what it does in the body at the cellular level, which is the drug action, but it's also a whole lot like the pharmacologic drug class. So see how these things are related? So if you can remember one or the other, it will help you identify the drug. The route of administration means how are you going to give it. How you give it depends on how it's supplied. So quite often medications are supplied in more than one form. For instance, if you have a corticosteroid, it can be in a cream, it can be in a pill, it can be IV, or it can be in an IM injection. So there's a lot of different ways that the same drug can be given to someone, and it's the same drug. So basically, how is it supplied? It'll always list all of those, and then how will you give it? So just because it's a pill doesn't necessarily mean someone swallows it, because as you learn in your skills lab, sometimes you put those pills under your tongue and they disintegrate. Sometimes there's a lot of different ways you chew them. Sometimes you actually put a pill in an inhaler and it makes it into a little powder and you inhale it. So anyway, lots of different ways to give a drug. There are sometimes more than one choice in the same route. So for instance, sometimes there's capsules, sometimes there's pills, sometimes there's regular release, sometimes there's extended release or sustained release or whatever. Sometimes in an oral form you'll have a liquid, a syrup, or an elixir, or a suspension. Lots of different ways. Sometimes you'll have something that's injectable, say for instance, a drug that is in a vial, and you draw it up and you could either give it to the person as an injection in a muscle, or you can put it in a bag of fluid, further dilute it, like in a little bag of normosaline or whatever, and give it to them IV. So lots of different possibilities for route of administration. I lumped contraindications and drug interactions together. They're really not the same thing, but they're important for the same reason, and that is, what conditions does a person have that might make it dangerous for them to take this drug? or what drugs interact with this drug to make it dangerous for the person to take this drug. So, for instance, if you have someone who is taking the beta blocker, propranolol, we'll just stick with that drug, and they are diabetic, a beta blocker will inhibit that tachycardia and that jittery feeling that lets you know that you're having a hypoglycemic reaction. And so it's not always a good idea to give beta blockers to diabetics. There's a lot of worse things out there that contraindications, things like anticholinergic drugs and glaucoma and all kinds of stuff that you'll use. But basically, there are reasons that people should not take drugs. An allergy is always a reason, but it's possible for you to be allergic to everything. So just saying don't take if you're allergic to it is kind of a cop-out, because you know that. And so when you're writing these things down, look for the big important things. Look for the common things. In terms of drug interactions, there are different kinds of drug interactions. If you have a drug that is metabolized in the liver by a certain enzyme, grapefruit juice messes with that. If you have a drug that binds to calcium, anything with calcium like milk or an antacid binds to it. If you have a drug that binds to plasma proteins, it can compete with other drugs that bind with plasma proteins. Sometimes this gives you more available drug. Sometimes this interaction will give you less available drug. Just not so much important for you to know for our purposes, but what's important is what drugs interact with each other. The medication warfarin, Coumadin, has a big long list of interactions. Antidepressants such as MAOI inhibitors have a big, huge, long list of interactions. And there are some drugs, as I mentioned with the grapefruit juice, and MAOIs bring this to mind too, that don't just interact with other drugs, but they interact with foods. So Coumadin warfarin is a drug that inhibits vitamin K, and so if you are eating a whole lot of foods with vitamin K in them, then that will play fast and loose with your clotting. So it's really important to know the drugs and other things that interact with the medications people are taking. You could go crazy with this, and you could list 20 different things in each category. So what I would encourage you to do is pick the big ones, pick the common ones. Don't pick the esoteric thing that maybe 1 in a million person is going to have, but pick the things that most people are going to have or you're most likely to see in your practice. So you can really go crazy with adverse reactions too, because if you look in your drug book, there will be, several inches of words with adverse reactions on a page. So the important thing here, like I said before, is to pick out the biggies. So let's divide them into two categories. One is common. So what are the 3 or 4 most common things people experience? Sometimes it isn't dangerous. Sometimes it's just annoying. Sometimes it'll go away. So for instance, if you are taking a narcotic analgesic, it can make you sleepy, it can make you a little nauseated, a little lightheaded. It can also make you constipated. If you take it long enough, some of the things will go away, the sleepiness, the lightheadedness, sometimes the nausea even goes away. The thing that never goes away is the constipation. So that's important for people to know. This will happen and it'll probably go away. So don't stop taking the drug, hang in there. However, this, in this case being constipation, will never go away. So you're going to have to start thinking about a bowel program. So don't list 100 things here. Pick what you think are the biggies. And sometimes it'll even, depending on the book you have, it'll give you the percentage of people who have these side effects. And so that's real easy. If half the people who take the drug have a headache, well, gee, that's a common side effect. If 1 in a million people who take the drug have a headache, well, not so common. So use your common sense on this one. Severe. So this is really important. What is the worst, most dangerous thing that can happen if you take this drug? Usually an allergy is one of them. But again, you can have a severe allergic reaction to any medication, so look for other things. What do you need to warn them about that they might never think of? For instance, there are some drugs that will cause what they call Stevens-Johnson syndrome, which is a really weird sort of allergic autoimmune thing where you get a rash and your skin peels and your mouth and your face swell, all kinds of stuff that people would never associate with, say, a blood pressure medicine. So it's important to know that. Another one is if you look at anti-lipemic meds, and some of them will cause muscle pain. Well, you wouldn't think your cholesterol medicine causes muscle pain, but it does, and it's important to know that because they need to get off of it. So anyway, the biggies. And the other thing is when to call the provider or stop the drug. And this is a big deal because there are some drugs you don't want to stop immediately. So think about what they're taking, think about what the big reactions are, and then what do you need to tell them as far as stopping or calling for help. So we have talked a lot about assessment and giving medications as some of the most important things that you can do. And assessment is an important part of medication administration. Depending on what the therapeutic action of the drug is, there may be some parameters that are important to measure before giving. For instance, there may be a lab value. If you're giving potassium, it's useful to know what their potassium is. If you're giving an anticoagulant, it's useful to know what their bleeding times are. If you're giving an antihypertensive, it's useful to know what their blood pressure is. So these parameters are often related to that therapeutic action, and sometimes your orders will have those parameters. Hold if blood pressure is this. Hold if potassium is this. If their INR is this. So a lot of times it'll be in the parameters. If it's not, and you think it should be, that's a phone call, because you need to know what to do if you have a wacky vital sign or a wacky lab value. How do you proceed with medication administration? In the last slide, we talked about assessment, which is the first step of the nursing process. So you do your assessments, you determine you're going to give the medication. Giving the medication is your intervention, and then after you've given it, you assess for the effects of the medication. There are a couple of different ways to look at this. You could look at short-term effects. So if I gave them some Zofran, did that stop the nausea, or did they stop vomiting? If I gave them a pain medication, did their pain go away? If I gave them an antihypertensive, did their blood pressure go down? So these are some short-term effects that you can see almost immediately in some of these drugs, sometimes within half an hour or an hour, depending on the route that you give them and the drug. Then there's also long-term effects. How is this going over time? What effects do you see over time? A lot of neurodrugs are like this, drugs for Parkinson's or Alzheimer's or antidepressants. Some of those take 3 to 6 weeks before you see anything. And, you know, if you're depressed, it's hard to have patience. And so it's important that people know that. So the other thing that you look at long-term, well, actually short-term and long-term, sometimes are parameters like lab values. So for instance, did the potassium go up or down? Did the drug level for a drug like vancomycin go up and down? Sometimes you'll measure serial labs, which means that you're measuring the same lab over time. So you'll measure the vancomycin level 2 or 3 times over the course of 2 or 3 weeks and see if it's stable and see if it's therapeutic. You will sometimes measure actually a lot of times measure serial values for electrolytes, also for bleeding times if you're giving anticoagulants. A lot of different reasons that you measure the long-term effects of a drug. What do you document about this? Now, this isn't part of the med card, but I wanted to talk about it anyway because it's important for you to know. If something went wrong, what do you do about it? Or what did you do about it? So, for instance, if I were to take an antihypertensive and the person immediately got up and was so dizzy that they couldn't stand, that's a problem. Maybe we lowered their blood pressure too low. So, what did you do about it? Well, hopefully you sat them down, you took their blood pressure again, you documented that. Maybe that's a phone call. Maybe that's telling the person to hold on if they're going to stand up and let their blood pressure kind of equilibrate. There's no one right answer here, but I do want you to think about after you have evaluated the effects of the drug. If it was great, do you document that? Yeah, if the pain went away, sure you document that. If it was not so great, the pain didn't go away, then document what you did about that as well. Patient education is important for a lot of reasons. When we talked about side effects, it's important for you to let the patients know what to look for. And if they find it, if it's something that's not a big deal and will go away, or if it's something that's really important and they need to call the doctor immediately or proceed to the emergency room immediately. So if you think about the common and the dangerous side effects, those are important patient education things. How to take the med. How do you take it? And you may think that's silly, but not necessarily, because there are, again, some pills that you chew, some pills that you swallow, some pills that you dissolve under your tongue. It's very important that people know that. When do you take it? And I don't just mean the time of day, although that's important. Before meals, after meals, with meals. Before you go to bed, first thing in the morning, and then don't lay down for 2 hours after you take it. Lots of different timing factors with a medication. What do you take it with? With food? What do you not take it with? Do you not take it with milk? For instance, iron. Iron is not good with milk. However, if you take it with orange juice, that helps the absorption. So those kinds of things are important. What would you want to know if you were taking this drug? And that's a really good way to look at patient education. If you were taking this drug or your family member was taking that drug, what do you want them to tell you so that you know and are an informed consumer about taking this drug? Now, here's the thing. You can't list everything. You can go crazy on this one just like you can go crazy with the side effects. And so just the big ones. One thing that just popped into my head that I think is important too, because on the last slide we talked about labs. There are medications that you have to follow up with. You have to follow up with your blood pressure medications, which is kind of an easy thing to get your blood pressure taken. But there are some of them, like anticoagulants or some seizure medications, that you have to follow up with a visit to the physician or to the lab because you need lab results drawn. And that's an important thing to emphasize to people too. So again, just list the big ones. Nursing implications. So you're thinking, okay, she already talked to us about assessment, she talked to us about evaluation, she talked to us about teaching. What in the world else has to go in this particular column? Well, a lot, actually. I think of nursing implications sometimes as a cheat sheet for me, as the things that I want to remember as a nurse when I'm administering this medication. Administration details. For instance, you never push IV Lasix fast because it can cause people to have permanent hearing damage. You never ever give potassium IV push. You always dilute it and you give it in an IV bolus with lots of fluid and you give it slowly. There are certain things that you don't mix Dilantin with. It only goes with normal saline. All kinds of little hints like this for administration. How do you store it? Does it go in the fridge? Does it not go in the fridge? Does it need to be protected from light? How long is it good for? If I reconstitute this bottle or this vial of Solu-Medrol and I can give it every 6 hours, is it going to be good for the whole day so that I can use all the doses in it, or do I have to throw it away after one dose? The COVID vaccine, for instance, it's only good for just a few hours after you get it out, and so that's an important thing to know. What is it compatible with, which I just talked about a little bit, but there are certain drugs that are compatible with dextrose, D5W. There are certain drugs that aren't. So you got to know what you're mixing it with. Also, if you're giving something in an that you have to reconstitute, and you'll talk about this in your skills lab, but if the drug is in a vial, it comes in a powdered form, you squirt liquid in there, shake it up, and reconstitute it, and it becomes a liquid drug, what do you use? Sometimes you use saline, sometimes you use sterile water, sometimes you use other things. Sometimes you reconstitute it in that, and then you have to dilute it further. These are all nursing implications, and they are very important things for you to know. The patient doesn't necessarily need to know them, but they are biggies for you. This may be a little tough for you to see because the font is small, but I wanted you to see what a completed medication information sheet or a med card looks like. A lot of it is pretty self-explanatory. You'll notice that the therapeutic class and the therapeutic use are related, as we talked about. You'll notice that I did include the expected pharmacologic action, which makes a lot of sense because if you know what it does to help, then you'll also know what it can do to hurt. So that will help you with side effects. Common adverse reactions versus severe adverse reactions. A little bit of dizziness or tiredness is one thing. Dyspnea or heart rate of 30 is another thing. Stevens-Johnson syndrome is a life-threatening, serious allergy that needs attention. So again, differentiate between the common things that are not that big of a deal and the severe things that are that big of a deal. The nursing assessment pre-administration. For this one, of course, you would check the heart rate and the blood pressure. You'll usually have parameters for those. And then in evaluating the effectiveness, you're going back up to why are you giving it? And looking at their heart rate, their blood pressure, their migraines, that sort of thing. Patient education. This is one they don't want to stop taking suddenly, and because it is dangerous to do so. You want to talk about the things they need to report immediately, like the Stevens-Johnson syndrome rash, any kind of dyspnea because it's bothering the bronchi and giving them bronchospasm. You also want to teach them to take their heart rate and their blood pressure at home because that'll be an important assessment that they can do, or perhaps a caregiver or a partner or someone that they live with can help them with that. And then other nursing implications that are important for you to know. If it exacerbates the effect of some other CNS depressants. So if these people are taking other medications with it, you might want to think about that, and that might be something to teach them. Alters the results of some lab tests, gives some people problems with anesthesia. A lot of different things can happen. So as you can see, there's a lot of information here. I didn't write down the whole book. I did write this down. I did not copy and paste. You certainly can copy and paste, but I think that you don't retain it as well. And so I think writing notes down by hand, even if you're typing them, is good. Writing them down in handwriting is even better. So I hope this has been useful, and I hope that you will take my advice, find yourself a template that you like, and start making a drug file.